so I'll try to do him good. Let's go forward to the next slide. Welcome back for everybody from summer. The usual warnings or information that the presentation is going to be recorded and archived. Please use the Q&A button to post your questions. Use the raise hand feature for the hosts, unmute your phone, and for anything else, please post it in the chat. Next slide, please. This is slides about what's upcoming on September 9th. We're going to have Christine is going to talk to us COVID-19 patients with documented alcohol disorder and the higher cause of morbidity, mortality with COVID. And then on September 26th, we're going to have a presentation from Rachel on glycemic control, clinical outcomes in patients with COVID-19. And then on October 3rd, from the pregnancy domain, an update, and that'll include phenotype of a pregnancy and vaccine effectiveness from a big team, Rena, Elaine, Sarah, Crystal, and I'm sure others. Just as an ad lib here, the Biden administration has put an enormous amount of wants to put or is putting a lot of emphasis on maternal health. So you guys are really doing that team's really doing great work, and I think there's going to be a lot of interest in this. Next slide, please. Oh, goodness gracious! Today we're going to have Dr. Madlock present on social determinants of health. I can't tell you how much we appreciate all the work the social determinants of health team has done, and it's just been very impressive. I can't tell you how many times we use your name and the work you're doing, so thank you. I'm actually doing a short presentation, and since I'm already chatting, I thought I'd just switch the order and talk about AIAN, and we can give Charis the rest of the hour. So with that being said, let's do the numbers. We're at 75 sites. I do get to ad lib here. I think that you guys know that it's an amazing feat, and I just can't thank you all enough for all the work that everybody's done. To get 75 sites to work together is very impressive, and I'm just so grateful. I just want to thank everybody. That's about 18.1 billion rows of data. Again, not to brag about the team and all the things that everybody does, but think about that. You're not only bringing it in, but you harmonize it every week, and it's available for you the next week. I mean, it's amazing. So wonderful job. And of course, we're at almost 6.4 million COVID cases, over 15 billion people altogether. And just a reminder that the long COVID team, of course, have been enhancing the data with all sorts of great stuff, social determinants of health questions, ADT, admit, discharge, transfer data, which helps with hospitalization. There's some flow sheets that have come in, and I know I'm forgetting something right now, but it'll come to me in a minute. And then a plug for the PPRL data. We are targeting October to have linked CMS data in the system, and that will join the viral variant data, the mortality data. It's already there, so that's pretty exciting. The Medicare CMS data is Medicare 65 and older, with some special populations, people on dialysis, etc. We are, as soon as this gets added, we're going to start bringing in or working on Medicaid data for lots of reasons. Obviously, it's a different population, but just talking about maternal health, 40% of all pregnancies in America are delivered using Medicaid benefits. So there'll be a lot of data in there from CMS, and even with the CMS Medicare data, the CMS data is great data. It has its shortcomings that N3C doesn't have, and vice versa. The CMS data, doesn't miss a visit once you're a Medicare patient, there's no reason you wouldn't get benefits and claims, but it's missing outcomes of labs and diagnostic procedures. So our hope is that by having that extra data, you can start to fill in some of the gaps of missing visits. And anyway, so enough said. I want to talk to you about AIAN data, and that was a good slide. Whoever, are we going to show Hans are we going to have any slides for AIAN? If not, I have one ready.
Yeah, Ken, I was hoping that you could share your screen and go through your slides. Yeah,
that'd be great. I'm actually almost prepared. So let's see if I can share my screen. Are you all seeing the NCAT's website?
Yes, we are, Ken.
Great. Okay, so I want to talk to you about AIAN data, but before we get going, I just want to have a brief, allow me to pontificate just a little bit. I have learned an enormous amount from watching the people who've been working with the AIAN community and trying to get access to this data. And of course, I think one of the things that I don't think any of us don't know, but it's good to be reminded, is that, the United States government does not have a great history of working with this community, and their concerns about the use of any resources, including their data, is you can imagine that it's pretty sensitive. And so the NCAT's leadership, Joni and Meredith and Jennifer and Penny have been working for 2 years, believe it or not, to be able to, even though we had this data inside of the Enclave, to allow it to be used. And it was worth the effort, because this is a population that has a lot of issues that are different from other groups. But it's also a population that often gets missed or overlooked for all sorts of reasons. And so it did take a long time to get access to this data, or basically allow people to have access, because it's been in there. And I think that one of the sensitivities that I really can't emphasize enough, that as we've worked with this community, is that the community is very diverse, not surprising. They speak with lots of different voices. So, we had to try to thread that needle to try to keep everybody happy, but that's hard when people have different opinions and different concerns. But I think the one thing that we heard loud and clear, and I just want to say is as part of the code of conduct, which has now been changed, we really want to obviously emphasize what we already do, which is, protecting people's privacy, but also any tribal affiliation that an investigator tries to make is just not supported by the data. It's not in the data. We don't want you to do it. The tribal groups ask us not to do it. And I think that is one of their biggest concerns. So I really want to emphasize that doing research and making any assumptions or conclusions about tribal affiliation is not good and not allowed. So I know this. I know you guys know this. I just want to emphasize it, because having access to the data is really rare. It's a privilege, and I don't want to lose that access. So having said that, you heard my whatever. I want to move on to what we've done. So there's really a few things we've done, and on this page, this NCAT's page, this is the source of truth of AIAN, and how we got access to it and what you're going to get. There also will be posted in other places. We've changed the DUR to include some new language. So when you do an attestation, you're saying, I'm not going to use this data, this specifically AIAN. But what we've done as far as changing the data, the code itself, and this is live, is that self-identified AIAN, and that's really important, it's self-identified, which was always in N3C, was until a week and a half ago obfuscated as other. And so now the race category actually will show, we pulled those folks out of the other category and basically shown, and they're now listed as AIAN under in the race category. Again, it's self-identified, it was always there, it was just not visible. The other thing we've done, and all of these things we should always take a step back, was in consultation with the, it's called the tribal consultation. And one of the reasons I wanted to bring up the page is because you can see the links as tribal consultation report. There's actually a PDF of the entire report. This is really where we work with the community on what they wanted. And the thing they wanted to do with the zip code is that they were okay with this bringing the zip codes forward, where again we had obfuscated them to 000. Now they will be shown, just like the AIAN race will be shown. However, there is one difference, is that it will only be 3 digits, the first 3 digits. So normally in de-identified, you get the first 3 digits, but in the limited data set, you get all 5. In this case, for AIAN, it will only be first 3, no matter what level you're in. Data, these zip codes were predominantly Native American from rural communities. There was about 2,653, give or take none. But if any of those zip codes had a population of less than 20,000, just like any other population, they still remain 000. So I just want to let people know it's there. We want people to use it. We want to encourage people to use it. But I just wanted to let people know, some of the ground rules and see if there's any questions. I should say there's no special, there's no special requirement for application other than like normal, when you submit your DUR, you're saying, I'm going to use this is what I'm using it for, but there's no extra steps that are different from any other work. All right, well, I think there's a question. How many sites have opted in and are contributing tokens? Oh, darn good question. I think we're, this is a little bit question. This is from Jared. How many sites have opted in and are contributing tokens to PPRL data? And what is the lag in reporting for claims data that will be linked? Oh, darn good question. I'll look it up. Jared didn't put it in the chat, but I think we're like we're under half, but we're over a third. So it's 40% of this. I think we're like 31 or 32. This month, once this CMS data goes live, I will be sending out or get Mike Carrillo or Joni to send out a letter going back and trying to getting people to remind people that joining N3C now gives you access to CMS, and see if we can't pull in a few more folks. That would be so we'll just try to encourage more folks. And then one other plug is the viral variant data. There's been some technical delays, so there weren't as many sites as there were that we had hoped originally, but we have 3 more sites just coming in. So don't give up on us. It looks like Meredith, are you mic'd and ready?
She's not. She's an attendee.
Oh, can somebody allow Meredith to talk?
Yes.
Thank you. Meredith, are you on?
Hello, can you hear me now?
Yep, we can hear you.
Okay. It's like the Verizon commercial. Thank you. I just wanted to, echo what you were saying, Ken. You gave a great summary about the AIAN. And I'm sorry, I can't remember if you said, but the code of conduct has been updated, I believe, and just wanted folks to be aware of that. And then also, I think Ken and I and others are going to huddle about getting additional community input to see if there's anything else needed for standing policy documents or processes. But as he said, you know, we aren't expecting it to change in terms of the DUR submission process or anything like that. But if there are ways we need to communicate this out to the community, leveraging the system, what we really, as Ken said, really want to avoid is extrapolating or inferring tribal affiliation. And so if there are ways you think that we need to make that clearer, just let Ken or me or Melissa and Chris or others know, and we can certainly take a look together and sort of work collaboratively on that. But that was the only thing I just wanted to add. And otherwise, thank you all very much for your patience. As Ken said, we have been working on this for almost 2 years to the date. And we're very delighted that we got to a place where we can make these data available. So thanks, and thanks, Ken.
Oh yeah, thank you. So I'm gonna, unless there's any other questions, I'm gonna turn this over. Charis, Dr. Madlock, I'm gonna turn it over to you and stop talking.
Okay, I'm ready. Yeah, no problem. Let me just get my presentation up. Okay, so I'm going to be presenting actually on our county level analysis, which we're actually using public data. We actually use public data for this analysis. And one of the reasons we wanted to do public data analysis is just to demonstrate some ground truth about social determinants of health and outcomes at the county level that could help inform the rest of the research that we're doing. So this presentation is clinical, social, and policy factors in COVID-19 cases and deaths, methodological considerations for feature selection and modeling in county level analysis. So the full author list is here. This paper is published in BMC Public Health. Just like to give special recognition to Bill Adams, who was the senior author on this paper. He was really instrumental in drafting the goals. And then Ken Wilkins, who was the panel, he was our head statistician, and he can help answer any questions you might have about our modeling. So I'm sure many of you are familiar with social determinants of health, and if you look up any definition, it's going to include some variation of the conditions in which people live, work, and play. So it can be something like the walkability of a neighborhood that impacts the amount of exercise people get on average, which has downstream health outcome impacts. Education level impacts health literacy, which can impact how well a person can comply with their disease management. Things like environmental toxins can have disastrous direct effects on health. So the reason I wanted to kind of give a definition and have a visual up here is that in some of the work, a lot of the research that we've been doing, we're finding that in healthcare, people may throw out one or two variables to encapsulate social determinants of health, but it's really important to have a broad view and to understand that there are multiple dimensions to social determinants of health, and to really understand your outcomes, you've got to address these different areas such as healthcare access and quality, neighborhood built environment, social and community context, economic stability, education access and quality. And so those are the domains from Healthy People 2030. In addition to some of the ones that we might consider in general, there are also policies that can impact outcomes, such as in the case of COVID-19, masking has an impact on disease. Masking policies can have an impact on on compliance and different things like that. Wanted to have a little framework for social determinants of health, because it can get a little confusing when we talk about these determinants of health, because they're all often the same variables we use to talk about disparities. So there's different kind of determinants factors. There's your healthcare, individual behavior, environmental factors, physical environment, and of course genetics, and these can impact these in quality, morbidity conditions, by race, ethnicity, socioeconomic status. So these are variables that sometimes we're looking at the disparity, and sometimes we're trying to assess these values as determinants for another outcome. And of course, policies and programs can affect both the determinant and the outcomes. In the early days of the pandemic, many researchers coordinated quickly to put evidence to help the country make sense of the patterns of infection and mortality. It soon became clear that social determinants of health were associated with COVID-19 trends at the US county level. Looking at the association at the county level is important because that's the level at which policies are often made and resources are distributed. So I created a couple of charts to help us understand this research area and how they were conceptualizing it. So in addition to, so we looked at county level analysis that incorporated population health, like demographic characteristics, which are not included in this chart. And then it had at least one social determinant of health variable. And this could be something like poverty, etc. And so what we wanted to look at were some of the other kinds of variables that we would consider for this kind of research. And we really wanted to look at whether or not the research was comprehensive. So our first variable listed here is accounting for county level start. Now, in the papers that did account for county level start here, what they did is they would take they'd have a time for each county. It's how many days since the county had COVID present. Most of the research isn't even doing that. What we considered important is to actually try to adjust for when the county actually had COVID, so that you could look at, instead of looking at the early days of the pandemic as a whole for each county, try to look at when did from then on out. That's what we thought would be a good method. But what we found is that nobody was really doing that. And we thought, well, that might affect the results they're getting. Then sort of the other three really important areas for COVID-19 were health status of a county, health insurance, so that's access to care issue, and then health how many MDs were in a given area. So we could see that there were quite a few papers that at least addressed one of these things. The ones highlighted in yellow, these are the papers that addressed all of them. Also, we thought sheltering in place behavior is also significant. So we know that there are specific SDOH variables. And so not a lot of the papers were really incorporating some of these COVID-19 specific behaviors into their research. And then also we considered it important to assess at various endpoints. So what's going on in the early months of the pandemic, it's easy to see that that would be different than what would happen later on as the pandemic progresses. May not be important at different times as the country and counties are trying to respond to the pandemic. So this slide shows the different timelines that a lot of the papers were using. And so this is up to date to, before we were doing our research. So there's going to be some new papers out later, but we can see that there's a huge variation in the time frame people were looking at in order to assess this association. And so we consider this something that makes it a little bit challenging to compare the results across these papers. So from looking at all of this, we decided to address a couple of specific gaps in knowledge. So what are the factors that are important for different kinds of outcomes? So there are different categories of factors, but then there's also a lot of the papers, or most of them were looking at cumulative cases and deaths, but some of them are actually trying to identify features that might be associated with a burst of cases. So we decided to look at the max for each county, what was their maximum 14-day rolling average of cases and deaths. Most social determinants of health in COVID models leave out three important factors. COVID policies, so they're not necessarily including anything about whether a county had shelter in place before they got the county. And a lot of that has to do with the fact that since people weren't adjusting to the county start, they weren't really looking at the data. A couple papers even addressed this point, and they assumed that most counties wouldn't have had a policy in place. Is actually, there were quite a few counties that would have a state level policy before they actually had COVID present. A lot of these papers weren't including sheltering in place behavior. That was being researched separately. So there at this time was a big body of literature around shelter in place behavior and outcomes, but it wasn't well incorporated into the social determinants of health research. And then additionally, essential worker who is out and about, we wanted to incorporate that. We also thought that we need to be able to assess how the choice of endpoints for cumulative counts and for other outpoints actually affects our model. So because we can see that there are a lot of different papers with different types of features they're looking at and different types of endpoints, we don't know which associations are spurious and which maybe were important for the early days of of a county having COVID, and what would be important, like no matter what endpoint. So our considerations, we wanted to look at how does SDOH explain variation in the COVID-19 incidence and mortality during a couple of different endpoints. So basically we chose, 1 month, 2 month, 3 month, 4 month, 5 month, and 6 month. These are overlapping endpoints, but we wanted to look at, okay, if we model it with 30 days versus 60 days versus 90 days, et cetera, how do things change? We wanted to look at if adding these, if being comprehensive, does this change what ends up being significant? And our social determinants of health associated with high all-time 14-day averages. So looking at these cumulative, not just the cumulative variable, so this bursts. So it's easy to say that the conditions in which people live, work, and play impact their health. What is actually more challenging is knowing what features matter to what outcomes, how to measure that feature, how to know, do you have biases in your data, and how to validate your measure. So we also know that there can be some issues with generalization. So the question is, can we capture the information we truly need to understand and anticipate people's health? Do we have the information available? In other words, could we understand the fundamental interconnectedness of all things such that we can see the solution to each problem as being detectable in the pattern and web of the whole? So this is Dirk Gently. He's the lesser known main character in a series of books by Douglas Adams. And this is a character that, understands that there is the interconnectedness of all things that lead to an outcome. And so sometimes I think with social determinants of health, it's very complicated because there are all of these interconnected variables that we know impact health, but identifying which ones are important, having the measure and everything, this is what's really, really challenging. And so what we did is we really ended up spending a lot of time thinking about this, thinking about the features and the connections that would be important. And we recognize that there's only so much we can do to really measure and assess these, and that a lot of our features really might be proxies for something else because we can't truly represent all of these interconnected social variables that might lead to our outcome. So what we ended up doing is we wanted to go to the social determinants of health domains that we looked at earlier, and we wanted to make sure we had good representation across those domains. The second thing is we wanted to look at the socio-ecological model of health. So this looks at kind of the different levels that you would have for any variable. So a social determinant variable can happen at the individual level. And if any of you are familiar with our domain team, that's what we're actually focusing on now, are those individual level social determinants of health. But there are also variables at the interpersonal level. So that could be something like, interpersonal discrimination, something at organizations. So that could be with your healthcare service, communities. So just features of your community and maybe social cohesion in your community, and then society and policies. And so really we wanted to think wanted to be pretty thoughtful about thinking of things across these different variables. So what we did is we came up with a couple of categories that we thought would be important. So looking at vulnerable populations, which a lot of the research on SDOH at the county level looks at, population characteristics such as density, adults with college degrees, so getting at that education level, Black-white segregation. And so this is going to get at some of the structural issues with individual groups and their access to care and access to resources. The current health status of a group, so that's actually an individual level variable that gets kind of rolled up at the county level. Resource deprivation, access to care, so looking at health insurance, and also MDs per 1,000 people. We included different essential healthcare worker variables. So there were a couple essential worker categories that we included. And then because this is COVID-19, traveling behavior is very important. Two, I want to highlight is the prior 7-day median time home. So this is before a county would have COVID, how much time or that gets derived from looking at cell phone tower pings. Also COVID-19 policies. So did a county have a policy in place before they had COVID present? How long had it been since the pandemic start? We wanted to see, do counties that get COVID early in the pandemic, is it maybe more trouble for them? And then the ones later in the pandemic, you know, maybe they've learned something, or the ones later in the pandemic, do they kind of like, you know, not take it as seriously? And so then it's maybe a little worse, looking at things like that. Also, how many days were, for counties that were sheltering in place, how many days were they sheltering in place? And we also wanted to account for the percent tested, which we couldn't get at the county level just because it isn't reliably available at the county level. It's only available at the state level. Now, of course, we can have data blind spots. So this is something to consider and think about, but because it is a data blind spot, there may be some data that we just cannot collect, or maybe something that we're not thinking about. So with this kind of research, that's just something that we have to consider. Oh, somebody had a question about RUC. Those are the rural urban codes. So it's just the level of rurality for a county. So we considered a county start date to be 1 case per 10,000. Our outcomes were cumulative cases that we adjusted ours per 100,000 for all our endpoints. So we wanted to predict that we kind of thought that some variables would only be statistically significant in the early period and some would be later, that we might differ from others because we're controlling for a different set of variables. Okay. So we used a generalized variance inflation factor to identify variables with high multicollinearity, which is appropriate for a mix of categorical and numerical variables. So the ones that we ended up removing were in health status, resource deprivation, and traveling behavior. We used the mixed effects generalized linear model. We ended up using negative binomial regression because it's appropriate for count data with the presence of heteroscedasticity and over dispersion. So heteroscedasticity is a measure of unequal scatter, which is a problem just because ordinal least squares assumes that all the residuals are drawn from a population with a constant variance. And over under dispersion means that the residual variance is larger or smaller than expected. Variables, and we use state as a random effect just because there's going to be variation just by the state level, and also there's going to be some issue of counties in the same state just being being kind of affected by each other. So we tried to use state as a random effect to soak up some of that So our county level SDOH factors and outcomes. So I'm not going to show this for all of the outcomes just because we have quite a few tables, but we had 26 factors that ended up being significant for at least one of the endpoints for the cumulative case models. So these are just these significant variables shown positive association, so that these variables were associated with higher cumulative counts, and the orange is negative, so those would be associated with having fewer counts. So some of the variables that you can see are significant in blue across all of our endpoints are things like the percent foreign born, the number of days since pandemic start. So those later counties were worse off, and that may be because that can be for a lot of reasons, but that's just what we found to be consistent. Percent Black and then Black-white segregation. These were also very significant variables. And in the orange, we can see some of the ones that were significant were the days sheltering in place at the start, the adults with degrees, and the percent public assistance. So that one was a little bit tricky, but research shows that even at the neighborhood level, you see the same kind of phenomenons, because using public services can be protective of different things. So it is beneficial to have people who are on public assistance, and that may be why it's protective, or there could be other, it could be a proxy for something else. This is looking at the cumulative deaths. So we see that there's fewer factors. In the previous slide, it was 26 factors. In this one, it's 21. We see days since pandemic start, percent foreign born, percent Black being very significant for across the models for this one as well. The prior 7-day median time home, sheltering in place, these are also important as protective factors, indicating that even when controlling for social determinants of health, a lot of the behaviors and policies were ended up being very important within the cases and deaths. So we wanted to get a sense of the overall what was really going on across our model. So these are the variables that would have been significant for at least 4 to 6 endpoints across each of these cases, across each of our outcomes. So right here, if we look at the 14-day for Black-white segregation, that means that this was significant for 4 to 6 endpoints for 14-day cases, cumulative cases, and cumulative deaths. That's what that means. So it's like across most of the models, was it significant? And we wanted to look, so we can see that there are for variables that increase either the cases or deaths, percent Black, percent foreign born, and days since pandemic start. These are the ones that they were significant for each of our outcomes across most of their endpoints, indicating that vulnerable populations and some of these COVID-19 kind of behaviors or policies were very significant for increasing those. For the factors that we can kind of consider protective or at least associated with fewer cases, days sheltering in place at start and median time home were the only ones that were significant for most endpoints across all of our outcomes. We can also see that some of these root codes were significant. So a root code of 1, these are like our biggest cities. Root code of 2, this is still urban. And then 4 through 9, those are going to be more of like the rural or adjacent. They might be smaller places that might be adjacent to a metro area, but not necessarily considered metro themselves. We can see the categories we see represented are population characteristics, vulnerable populations. Access to care was only significant for cumulative cases. And then traveling behavior and resource deprivation are some of the other categories. Essential workers, that was a category that isn't included on this. So for each model, we wanted to look at the fit. So here we're looking at the results of the QQ plot. We also have, it's hard to see because it's very small. And this is for our cumulative deaths, but we also did the Kolmogorov-Smirnov test for fit. And that was, there's only a good value for that for the 30-day and 60-day model, even though there's still somewhat decent fit for the 90-day. But we can see that the model fit kind of degrades as the time frame increases. And this was actually a lot more extreme for our other endpoints. So we have the best, we ended up with the best, and you can see it the red in the middle is just indicating that there are dispersion issues. And part of that's just the size that with the package we're using, it's going to be dispersion's just more likely to be significant. Any dispersion will be significant just with a larger size of data. But we can at least see that there's better model fit for the 30 days. For the larger time frames, the model was less accurate, and this is likely to be due to changes in policies, changes in behavior, a lot of factors that we weren't actually able to capture. So the last thing we wanted to do to kind of test out kind of how consistent our results were going to be under different conditions is to alter the county start date to the day each county reached 10 COVID-19 cases per 10,000 as opposed to 1. So important variables that ended up being important in the main analysis, so that we're in that visual that I showed where it's showing the significant variables across the endpoints, and the sensitivity analysis was a shorter list. So adults with college degree, days sheltering in place, prior 7-day median time home, % Black, foreign born, % over 65, Black-white segregation, and days since pandemic start. These ended up being the variables that were still significant when we moved the requirement for our county start date. But we did see that there was a difference, so that by looking at this, we did see some changes here. End of my presentation. I thank you all for being here to attend. If you would like to join our domain team, we meet every other Tuesday at 3 o'clock and Central Standard Time, and you are welcome to contact me. Thank you.
Thank you. That was wonderful. I just saw a hand go up, but it went down. Sam B, are you? Sam B was asking a question about a lot of the data is ecological data, and I wasn't. And then there was a response. What does that mean? So I'm just curious, Sam, or if that was clear, and if someone could answer that question. Or did you mean economic? Sam, you wrote, how do you account or perhaps compensate for the fact that a lot of data is ecologic? Can you clarify that question? It's Sam Bozetti, if someone could open up the mic. Oh, there goes Sam. Sam, can you you should be unmuted now.
I am?
Yeah, we can hear you.
Oh, great. Yeah, what I'm asking is, you don't know who is in which category. I mean, Clarice, I'm sure you wrestle with this all the time, but I'm just wondering if you did anything or what you do to try and handle it. For example, say the proportion, maybe in areas where the proportion of Blacks is higher, it's whites who are getting more disease because the people who live there happen to be particularly disadvantaged in some way, and people who live in that area. Or Similarly, it may well be that the people who are suffering the endpoints are not the people who have the condition that you're testing. And I'm just wondering, there's no really great way around it, but I'm just wondering what you're doing about it, because I'm sure you're aware.
Thank you. That's a really great point. I actually have one of my PhD students, what she's been looking at is you can get the county case counts for some racial minority groups, including Black. So looking at when it comes to the cumulative cases in that racial group, do you start to see the same trends? The other thing now is that we're starting now in our current research to incorporate some of these variables in the patient level analysis, so we can see if we're finding the same associations. But that's a really great point, because we don't know when we include the vulnerable populations, we don't know if it's those vulnerable populations that are getting it. So that's kind of the direction we're going in now, is to have a combination of the county level and patient level. And that's also the reason we wanted to really be comprehensive, also to be able to control for some of the other factors. But even then, we're not sure, is it the vulnerable populations or is it some other, a lot of these variables we kind of consider more, they could be proxies for other things. And now our work is to figure out what they might be proxies for, and how they might be associated with individual level analysis. Thank you.
And are there any other questions that we're missing? And if not, I would like to ask one a little. It's maybe both Richard and Charisse. So the COVID, the Recover team has added recently 4 types of data. I said this at the beginning, but I couldn't remember one of them, which was, we mark it if it's a person's visit was long COVID clinic. The ADT, as I mentioned, oxygen device values in the flow sheet, but the social determinants of health added 6 domains: financial, resource strain, food insecurity, social connectedness, stress, transportation, and housing. I think my question is, are those, it's just really difficult to get this data. It's almost like the EHR is just the wrong spot, right? So I guess my question is more of a broad one, is where should we look to get more social determinants of health? And are these questions, though they're not perfect, are they of value to you?
Yeah, that's a good question. And that's something that we also deal with. And Bill Adams is on here, and he's collection of this data at the if you're asking at the patient level, those domains are very helpful. They map to I have another presentation that maybe I can give to this group later on the patient level group and how they map to some of the domains of interest. So they are very valuable. Kind of what we've discussed in our group is that some of the longer screening tools can be a little hard to implement, hard to get people to fully answer, because it can be a lot of questions. So being able to have those domains is really helpful. We still plan to use some of the county level ones, because those are still gonna be drivers, if we go back to our visualization that Juan Espinosa created for us. I forgot to give him credit for this. We can see that with the socioecological model of health, there's individual level variables, but it still goes up all the way to societies and policy. And we want to be thinking comprehensively sort of along this, I guess, this hierarchy. It's not quite I guess it is a hierarchy.
Thank you. Question from David. David, can you, I guess Charlie, can you see the Q&As?
Yeah, okay, so I feel like, cases and deaths are reported out by public health agencies. I believe that they're actually based on where they're tested, received care. So I'd have to go back and look into that exactly. But I believe it is just where they were tested or received the care.
Thank you. And then there was a question from David Schauner.
When you say you're curious about the basis of the heteroscedasticity, do you mean in what we observed with the modeling that we were doing? And I think we were using some Poisson distributions at that point that had those sorts of issues. But I don't know, it's been a while. I don't know if Ken wants to tackle that question.
We covered it, yeah. That's how we helped finesse that with just the vanilla count models of Poisson assumptions. He did have a question of follow-up of temporality. I'm not sure if you wanted to talk about that, but that kind of bakes into the different outcomes of 30, 90, so on. Cumulative outcomes as we change them. We can always talk with David offline if need be.
Are you asking, Ken, are you asking for Dave to be unmuted?
I don't think he needs to. I mean, I guess that's, he had a question temporal that if he could be unmuted and clarify what it is. Sure.
Because we don't generally allow David to be unmuted in the more, no, I'm sorry, that's terrible. Dave, can you
Yeah.
elaborate?
Thanks, Ken. I liked your tongue-in-cheek comment. Yeah, and it's for good reason. No, no, I was wondering if the change in standard deviation over time that you observed, heteroscedasticity, it's hard to pronounce, was temporal because there are different forms of that.
I recall it being so, Sharice, but I mean, again, if it sort of look at it, at how to best accommodate that, we can maybe get into a side conversation on the before and after.
No.
So we were having that with the previous, so we used the negative binomial regression because we were getting heteroscedasticity with our Poisson modeling. And I recall, and it was across all of our models that we were having this problem.
Right.
But
Okay.
we weren't having it with what we ended up with. This is just to explain why did we end up with this type of modeling. Because we were having that problem with other models that we were using.
Okay, so you were able to solve that.
Yeah, I guess I didn't explain that well, but.
Okay.
That's what I meant by the before and after. It was an issue before. This was one way to finesse it, and we could, if you wanted to get into the details of how it did appear to happen over time, and then have to be a bit more finessed by this extended model, count model with the negative binomial and the random effects per state. That's part of the after was shown a bit by Sharice already with some of those diagnostics where things kind of fall in where you'd like them to visually.
Right. No, I saw that. I see now that you've solved that issue. I didn't mean to sort of beat a dead horse, but what you'd seen before and was the heteroscedasticity basically entails differences in standard deviation. I was wondering if that was observed over time or if it was a function of an independent variable, but we can take that discussion offline. And the only other comment that I just wanted to mention was, I was very, very impressed by the effect of segregation, and we're very well aware of the negative repercussions of segregation on homicide rates and a variety of different things. But this is just yet another incredibly powerful argument for the deleterious effect of segregation. And obviously this has policy implications. Anything that can be done to address that would be helpful.
Yeah, that's a great point.
Indeed.
I'm gonna we have just 2 minutes left, and Bill Adams, I'm trying to ask everybody to be unmuted. Can we Bill, if you're still here, would you mind talking about your recommendation? I'd love to hear more about what you're thinking. We may have, I don't know if Bill's still here. Well, I think that, we need to get better social determinants of health. It's always a challenge.
Sorry about that.
Oh, no, not at all. Thanks for
figure it out here. So one thing that we discovered in this process of being the social determinants group is that initially there was huge skepticism that there would ever be any data at the patient level to start to look at this. And we at my safety net hospital have been doing it for quite a while. So we just said, well, let's try our data and figure out how to move it in. And so we did some interoperability data mapping work with Jimmy Fong, especially leading the charge, and we're able to send in our data. And then I think the long COVID data and OCHIN and others are starting to do it. And then within EPIC, there's a dedicated social determinants of health wheel or module that is also starting to collect data for those 6 domains that you mentioned before. I do think it's going to be biased towards high-risk populations because that's where I think the effort is getting traction most right now. But eventually, I think it will become part of routine care and maybe required. I live in Massachusetts, so I think it may be a higher priority. Not every state will be the same either. But I think at the end of the day, the type of work that Charisse did that brings place-based data into these data systems and ultimately links it to the clinical data and whatever individual data is available is probably going to be the richest way, because we probably won't, as you said, have one way to do it. But the more multidimensional our models are, which is where N3C is amazing in what it does, I think the richer our insights are going to be. So that would be my takeaway.
Thank you. And thank you for letting me put you on the spot. I really, really appreciate it. It's 6 o'clock. Again, thank you to everybody. The community's really been amazing and much appreciative. And you all take care and stay safe. Bye-bye.